Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based review of Gaucher disease, prepared for general pediatricians. Gaucher disease is the most common lysosomal storage disorder caused by deficiency of the enzyme glucocerebrosidase. We will work through 14 carefully crafted clinical cases covering clinical recognition, the bone crisis, the underlying biochemistry, the diagnostic workup, the hematologic abnormalities, disease classification, the differential diagnosis, treatment, biomarker monitoring, chronic bone complications, oral therapies, radiological findings, genetic counseling, and management in pregnancy. Let us begin. Clinical Case 1. A 6-year-old boy presents with 8 months of increasing abdominal distension, easy fatigue, and recurrent bruising without significant trauma. On examination, the spleen is palpable 10 centimeters below the left costal margin. The liver is mildly enlarged, and his weight is at the 10th percentile. Laboratory studies show hemoglobin of 9.2 grams per deciliter, platelets of 78,000 per microliter, and a white cell count of 3,400 per microliter. What diagnosis best explains this clinical picture? Option A, Gaucher disease. Option B, acute lymphoblastic leukemia. Option C, Epstein-Barr virus infection. Option D, portal hypertension from biliary atresia. The correct answer is option A, Gaucher disease. The key to this case is the combination of massive splenomegaly with pancytopenia, meaning anemia, thrombocytopenia, and leukopenia together. In Gaucher disease, lipid-laden macrophages called Gaucher cells infiltrate the bone marrow and the spleen, which produces both the organ enlargement and the low blood counts. Acute leukemia would usually show blast cells. An Epstein-Barr infection has an acute course with atypical lymphocytes, and biliary atresia presents in early infancy with jaundice. The clinical lesson is to always consider Gaucher disease in a child with unexplained hepatosplenomegaly and cytopenias. Clinical Case 2. An 8-year-old girl with known Gaucher disease type 1, currently on enzyme replacement therapy, presents with sudden onset severe right thigh pain for 12 hours. Her temperature is 38.4 degrees Celsius. The right thigh is tender, with no erythema and no swelling. The erythrocyte sedimentation rate is 72 millimeters per hour, and the C-reactive protein is 48 milligrams per liter. The white cell count is 9,200 per microliter, and platelets are 88,000 per microliter. X-ray shows osteopenia and an Erlenmeyer-Flask deformity with no fracture. What is the most appropriate immediate management? Option A, intravenous ceftriaxone for presumed osteomyelitis. Option B, increase the enzyme replacement therapy dose immediately. Option C, analgesics and intravenous hydration for a Gaucher bone crisis. Option D, bone marrow biopsy to rule out malignancy. The correct answer is option C, analgesics and intravenous hydration for a Gaucher bone crisis. A bone crisis represents an intraosseous infarction. Gaucher cells occlude the medullary blood supply, producing ischemia and acute severe pain that can closely mimic osteomyelitis, including fever and elevated inflammatory markers. First-line management is supportive. Adequate analgesia with nonsteroidal anti-inflammatory drugs or opioids, together with aggressive intravenous hydration. Steroids should be avoided because they can mask fever and worsen the risk of osteoporosis. Increasing the enzyme dose does not relieve the acute crisis, and a biopsy is not needed when the picture and imaging are characteristic. Clinical Case 3. The parents of a 6-year-old boy ask you to explain their son's condition. His glucocerebrosidase enzyme assay shows activity at 3% of mean normal. What is the direct biochemical consequence of this enzyme deficiency? Option A, accumulation of galactocerebrosidase in oligodendrocytes. Option B, defective degradation of GM2 gangliosides in neurons. Option C, failure of sphingomyelin breakdown in macrophages. Option D, accumulation of glucosylceramide in macrophage lysosomes. The correct answer is option D, accumulation of glucosylceramide in macrophage lysosomes. The deficient enzyme is glucocerebrosidase, encoded by the GBA1 gene, and the condition is inherited in an autosomal recessive pattern. The normal job of this enzyme is to break down glucosylceramide. When it is deficient, this substrate becomes trapped and accumulates inside the lysosomes of macrophages. The macrophages become large and distended, forming the characteristic Gaucher cells, which have an eccentric nucleus and a crinkled tissue paper appearance of the cytoplasm. These cells then accumulate in the liver, the spleen, and the bone marrow, which explains the clinical features of the disease. Clinical Case 4. A 5-year-old girl of Ashkenazi Jewish heritage presents with splenomegaly, anemia with a hemoglobin of 8.8 grams per deciliter, and thrombocytopenia with platelets of 65,000 per microliter. Gaucher disease is suspected. What is the most appropriate first diagnostic test? Option A, leukocyte acid beta-glucocerebrosidase enzyme assay. Option B, bone marrow biopsy. Option C, GBA1 gene mutation panel. Option D, serum chitotriosidase level. The correct answer is option A, the leukocyte acid beta-glucocerebrosidase enzyme assay. This enzyme assay is the gold standard diagnostic test. Enzyme activity below 15% of mean normal is diagnostic of Gaucher disease. The test must be performed on leukocytes or on a dried blood spot, and not on plasma, and it should be done before genetic testing. Genetic analysis of the GBA1 gene is then performed afterward because it adds prognostic information and guides genetic counseling and family screening. A bone marrow biopsy is not required to make the diagnosis, and chitotriosidase is a monitoring tool rather than a diagnostic test. Clinical Case 5. A 10-year-old boy with Gaucher disease presents with routine blood work. His hemoglobin is 9.0 grams per deciliter with a mean corpuscular volume of 85 femtoliters. His platelets are 52,000 per microliter, and his white cell count is 2,800 per microliter. The peripheral film shows no blast cells, and vitamin B12, folate, and iron studies are all normal. What is the primary mechanism for his cytopenias? Option A, autoimmune hemolytic anemia from cytokines. Option B, chemotherapy-related myelosuppression. Option C, bone marrow infiltration plus hypersplenism. Option D, nutritional deficiency from malabsorption. The correct answer is option C, bone marrow infiltration combined with hypersplenism. There are two mechanisms working together. First, Gaucher cells infiltrate the bone marrow and crowd out normal blood cell production, reducing the output of red cells, platelets, and white cells. Second, the enlarged spleen sequesters and destroys circulating blood cells, which is the process of hypersplenism. The result is a normocytic, normochromic anemia, together with thrombocytopenia and leukopenia, and importantly, no blasts on the peripheral film. Normal nutritional studies and the absence of blasts make deficiency states and leukemia unlikely in this patient. Clinical Case 6. A 14-month-old infant boy presents with profound hypotonia, horizontal supranuclear gaze palsy, vulvar dysfunction, and bilateral pyramidal signs. Massive hepatosplenomegaly is present. He has been on enzyme replacement therapy for 2 months, with visceral improvement, but his neurological deterioration continues. His glucocerebrosidase activity is 4% of normal, and his GBA1 genotype is L444P on both alleles. Which Gaucher disease type best describes this patient? Option A, type 1, non-neuronopathic. Option B, type 3, chronic neuronopathic. Option C, Niemann-Pick disease type C. Option D, type 2, acute neuronopathic. The correct answer is option D, type 2 acute neuronopathic Gaucher disease. Type 2 has an onset before 6 months of age with rapidly progressive neurodegeneration. The hallmark signs are horizontal supranuclear gaze palsy, bulbar dysfunction, and neck retroflexion, all of which fit this infant. A critical point is that enzyme replacement therapy does not cross the blood-brain barrier, so it improves the visceral disease but provides no neurological benefit. Type 2 disease is typically fatal by age 2 to 4 years. The L444P genotype on both alleles is associated with severe neuronopathic disease. By contrast, type 1 has no central nervous system involvement, and type 3 follows a more chronic course. Clinical Case 7. A 7-year-old presents with splenomegaly, anemia, and thrombocytopenia. The glucocerebrosidase assay is still pending. Which lysosomal storage disorder most closely mimics type 1 Gaucher disease and must be excluded by specific enzyme testing? Option A, Niemann-Pick disease type B, which is acid sphingomyelinase deficiency. Option B, Pompe disease, which is acid alpha-glucosidase deficiency. Option C, Fabry disease, which is alpha-galactosidase A deficiency. Option D, mucopolysaccharidosis type 1, also known as Hurler syndrome. The correct answer is option A, Niemann-Pick disease type B. Niemann-Pick disease type B is caused by deficiency of acid sphingomyelinase, which leads to sphingomyelination accumulation in macrophages. It closely mimics type 1 Gaucher disease because both conditions cause hepatosplenomegaly and cytopenias due to macrophage storage. A useful distinguishing feature is that Niemann-Pick type B characteristically involves lung disease with pulmonary infiltrates, and it does not cause the bone crises seen in Gaucher disease. Because the clinical overlap is significant, the two cannot be reliably separated on clinical grounds alone, so specific enzyme assays are essential to confirm the correct diagnosis. Clinical Case 8. A 9-year-old girl with Gaucher disease type 1 presents with a hemoglobin of 8.4 grams per deciliter, platelets of 42,000 per microliter, a spleen 12 times the normal size, and recurrent bone pain episodes. Her parents agree to begin treatment. What is the recommended first-line treatment? Option A, oral miglustat 3 times daily. Option B, splenectomy followed by observation. Option C, intravenous imiglycerase every 2 weeks. Option D, oral eliglustat with CYP2D6 genotyping. The correct answer is option C, intravenous imuglycerase, which is enzyme replacement therapy. Imuglycerase is given as an intravenous infusion every 2 weeks. The standard starting dose is 60 units per kilogram, which can be reduced once treatment goals are reached. With effective therapy, the hemoglobin typically improves over 6 to 12 months, and organ volumes reduce over the following 1 to 2 years. Enzyme replacement therapy is the established first-line treatment for symptomatic type 1 Gaucher disease. An important limitation to remember is that it does not cross the blood-brain barrier, so it provides no neurological benefit in type 2 or type 3 disease. Clinical Case 9. A 12-year-old boy with Gaucher type 1 has been on imiglycerase enzyme replacement therapy for 18 months. His complete blood count has improved, with a hemoglobin of 11.8 grams per deciliter and platelets of 145,000 per microliter, and his spleen volume has decreased by 40%. However, his chetotriosidase assay returns undetectable because of a CHIT1 pseudodeficiency mutation. What is the best alternative biomarker to monitor disease activity? Option A, serum ferritin. Option B, angiotensin-converting enzyme. Option C, CCL18 alone. Option D, plasma glucosyl sphingosine, also known as lyso-Gb1. The correct answer is option D, plasma glucosyl sphingosine, or lyso-Gb1. Lyso-Gb1 is the most sensitive and specific biomarker for Gaucher disease, and it is useful across all disease types. A major advantage in this case is that it remains reliable even when chitotriosidase cannot be used. About 6% of people carry a CHIT1 pseudodeficiency mutation that makes the chitotriosidase assay uninterpretable. Lyso-Gb1 also tracks the response to treatment, falling with effective enzyme replacement therapy. Ferritin and angiotensin-converting enzyme are nonspecific, and CCL18 is a less preferred alternative. Clinical Case 10. A 16-year-old male with Gaucher type 1 has been on enzyme replacement therapy for 4 years. He now presents with progressive right hip pain, worse on walking, and relieved by rest. A hip X-ray shows flattening and subchondral collapse of the right femoral head, and magnetic resonance imaging confirms avascular necrosis. Which factor most likely contributed to this complication? Option A, delayed initiation of enzyme replacement therapy allowing pre-existing bone marrow infiltration. Option B, high-dose corticosteroid therapy during bone crises. Option C, pulmonary hypertension reducing blood flow to the femoral head. Option D, Gaucher-related coagulopathy causing microvascular thrombosis. The correct answer is option A, delayed initiation of enzyme replacement therapy allowing pre-existing bone marrow infiltration. Bone marrow infiltration by Gaucher cells is progressive, and once structural damage occurs, it is irreversible. Early enzyme replacement therapy can prevent avascular necrosis, but once osteonecrosis is established, enzyme therapy cannot reverse the structural bone damage that has already happened. The hip is the most commonly affected joint. Magnetic resonance imaging confirms the subchondral collapse, and joint replacement may be required in advanced cases. The central message is that avascular necrosis is irreversible, so starting enzyme replacement therapy early is essential to prevent it. Clinical Case 11. A 35-year-old woman with Gaucher type 1 declines intravenous enzyme replacement therapy because of needle phobia. Her disease is mild, with a hemoglobin of 11.2 grams per deciliter, platelets of 112,000 per microliter, and a spleen 4 times the normal size. She requests an oral treatment option and is willing to undergo pharmacogenomic testing. Which oral therapy requires CYP2D6 genotyping before prescribing? Option A, miglustat, also known as Zavesca. Option B, aliglustat, also known as Serdelga. Option C, Ambroxol, used as chaperone therapy. Option D, N-acetyl-L-cysteine. The correct answer is option B, eliglustat. Eliglustat is an oral substrate reduction therapy and an alternative to intravenous enzyme replacement therapy for adults with type 1 Gaucher disease. It works by blocking glucosylceramidase synthase, the enzyme that makes the substrate, so that less substrate accumulates. Eliglustat is metabolized by the CYP2D6 enzyme, so genotyping is mandatory before prescribing because it determines the patient's metabolizer status and whether the drug is suitable and at what exposure. It is approved for adults only and is not approved in children. Miglustat is another oral option that does not require genotyping, but it has worse gastrointestinal tolerability. Clinical Case 12. A 13-year-old with newly diagnosed Gaucher type 1 undergoes skeletal x-rays. The radiologist reports a characteristic finding in the distal femur on both sides. What is this classic radiological finding? Option A, Codman triangle, periosteal elevation from subperiosteal hemorrhage. Option B, a hair-on-end appearance with a widened medullary cavity. Option C, Erlenmeyer-Flask deformity, failure of tubulation from Gaucher cell infiltration. Option D, a celery stalk metaphysis, transverse bands from interrupted bone growth. The correct answer is option C, the Erlenmeyer-Flask deformity. This deformity is a failure of normal tubulation of the distal femoral metaphysis. The cortex is widened and flared so that the shape resembles an Erlenmeyer laboratory flask. It is caused by Gaucher cell infiltration replacing the normal bone marrow and disrupting cortical remodeling. It is most visible at the distal femur, the proximal tibia, and the distal radius. It is a radiological sign rather than a painful lesion itself, but it indicates significant bone marrow infiltration. By contrast, the Codman triangle suggests osteosarcoma, the hair-on-end appearance is seen in thalassemia, and the celery stalk pattern occurs in osteopetrosis or congenital rubella. Clinical Case 13. The parents of a 10-year-old with confirmed Gaucher type 1 with a homozygous N370S genotype ask about long-term risks for themselves and their siblings who are obligate GBA1 carriers. Their uncle, an unaffected carrier, was recently diagnosed with Parkinson's disease at age 65. What is the correct statement about GBA1 mutations and neurological risk? Option A, GBA1 heterozygous carriers have no increased neurological risk. Option B, type 1 patients have zero Parkinson risk with no neurological form. Option C, GBA1 mutations cause Parkinson only in the homozygous state. Option D, heterozygous carriers have a 5 to 10 times increased lifetime Parkinson risk. The correct answer is option D. Heterozygous GBA1 carriers have approximately a 5 to 10 times increased lifetime risk of Parkinson's disease. GBA1 is in fact the strongest known genetic risk factor for Parkinson's disease. Among patients with homozygous Gaucher disease, roughly 5 to 7% develop Parkinson's disease over their lifetime. The mechanism involves glucocerebrosidase dysfunction, promoting aggregation of the protein alpha-synuclein, which leads to Lewy body pathology. The practical message is that all Gaucher disease families, including unaffected carrier relatives, should be counseled about this increased neurological risk. Clinical Case 14. A 28-year-old woman with Gaucher type 1, well controlled on imuglucerase enzyme replacement therapy, is now 10 weeks pregnant. Her pre-pregnancy labs showed a hemoglobin of 11.8 grams per deciliter, platelets of 128,000 per microliter, and stable organ volumes. She asks whether to continue her enzyme replacement therapy during pregnancy. What is the most appropriate approach? Option A, discontinue therapy immediately, as it is teratogenic and contraindicated in pregnancy. Option B, continue therapy throughout pregnancy, as it is safe and pregnancy can worsen Gaucher disease significantly. Option C, switch to oral miglustat as a safer alternative in pregnancy. Option D, discontinue therapy in the first trimester and restart postpartum. The correct answer is option B, continue enzyme replacement therapy throughout pregnancy. Pregnancy can significantly worsen Gaucher disease, with risks including worsening cytopenias and bleeding complications. Enzyme replacement therapy with imiglucerase is considered safe throughout all 3 trimesters and should not be interrupted in a patient who is already well controlled. It is important to note that miglustat is teratogenic and is absolutely contraindicated in pregnancy, so switching to it would be unsafe. The correct approach is to continue the established enzyme replacement therapy, which protects the mother from disease exacerbation while remaining safe for the pregnancy. Before we conclude, I want to tell you about our community on Patreon, named Pediatric Case Review. This community brings together all of our videos, systematically arranged by body system, so you can access every lecture in one organized place and study smarter. In addition, all of the lecture slides are available as images, so you can read, review, and practice every question anytime and anywhere. If you would like the details and want to know how to subscribe, please leave a comment below this post, and we will message you directly with everything you need to join. Let us summarize the key clinical takeaways. First, Gaucher disease is the most common lysosomal storage disorder, so consider it in any child with unexplained hepatosplenomegaly and cytopenias. Second, the enzyme assay is the gold standard. Leukocyte glucocerebrosidase activity below 15% of normal confirms the diagnosis, and no bone marrow biopsy is needed. Third, there are 3 distinct clinical types. Type 1 is non-neuronopathic and accounts for about 95% of cases. Type 2 is fatal in infancy, and type 3 is chronic neuronopathic. Enzyme therapy does not treat central nervous system disease. Fourth, start enzyme replacement therapy early because this prevents irreversible bone damage and avascular necrosis. Fifth, monitor with lyso-Gb1, the most sensitive biomarker. And sixth, heterozygous GBA1 carriers carry a 5 to 10 times higher lifetime Parkinson's disease risk, so counsel all families. Thank you very much for joining me through this case-based review of Gaucher disease. If you found this lecture helpful, please follow the channel for more informative case-based presentations across pediatrics. If you have any questions about today's topic or suggestions for future lectures, please leave them in the comments, and I will be glad to respond. Remember that this presentation is intended for educational purposes only and does not replace professional clinical judgment or current institutional protocols. Wishing you all the best in your practice, and I look forward to seeing you in the next case review.